Hello everyone, this is Dr. Rasho, owner of Rasho RX Precision. I am a clinical pharmacist and I'm specialized in pharmacogenomic. I obtained my doctorate degree in pharmacy from University of Colorado, and I am very passionate about pharmacogenomic and the way it can help us personalize patients' medicines depending on their genes for a variety of conditions. So I often talk to provider, pharmacists, physicians, nurses, and also patients. They have not heard much about pharmacogenomic, and when I discuss pharmacogenomic with those provider and patients, they get really excited and they want to learn more. So I decided to come up with this presentation, and to me, pharmacogenomic is the future of medicines, and everyone will eventually have their pharmacogenomic test done to help individualize their treatment for a variety of conditions. So without further ado, let us go ahead and dive in. And of course, I don't have any conflict of interest associated with this activity, other than that I provide pharmacogenomic testing and consultation as a part of services that I provide with my company. And also I provide medication therapy management. So next slide. Now we are going to talk about briefly talk about personalized medicines. So we are all different, therefore we react to medication differently. So if we have a group of patients with the same conditions such as depression, so for example, depression is very common right now, especially with COVID pandemic, and if we prescribe same medication to each and every one of those patients, we will see different responses. A group of these patients might have some benefit, and that's what is intended, improve their depression. Another group might have no response whatsoever, and we might need to increase the dose in order to see some benefit. The third group, however, may only experience side effects. So why do we see all these inter-individual variability in drug response? So my hope is that I can answer this question for you by the end of this presentation. And that brings us to our learning objectives and what you are going to learn from this presentation. At the end of this presentation, you will be able to learn what is personalized medicines and pharmacogenomics, describe how genetic variant can impact on medications, and also provide some real world example of medications that impacted by pharmacogenomics, and also identify some resources. So I will provide you with some resources or a food for mind to learn more about pharmacogenomics. Now moving to our next point, personalized medicine. Providers have been using patient characteristics such as age, body weight, liver function, kidney function, etc. to optimize therapy for many decades, but there is still a variability in drug response, and it can be anywhere from lack of response to toxicity. And it's predicted that anywhere between 20 to 95% of this variability in drug response is due to some sort of genetic variant, broadly pharmacogenomics. So now that we have talked about personalized medicines, let us discuss what is pharmacogenomics. So pharmacogenomics is a subset of personalized and precision medicines which study the relationship between variation in genes up to the whole genomes and variability in drug response and toxicity. And the goal of pharmacogenomics is to provide the right patient with the right drug at the right dose at the right time by identifying the biomarkers or genes that can predict the drug response and toxicity. And let us turn our attention to and talk about tailoring therapy. So now we know that one drug doesn't fit all. However, this is the current practice of medicines, that one size fits all. And we see every day that patients with any conditions such as depression or cancer, whatever is the condition is, the physician would prescribe a medication based on guidelines, and we will see that this group of patients have the same condition. So for example, in this case, a patient have colon cancer and they get a treatment, but we see that one group get the benefit, which is good, and then the second group have no benefit whatsoever, and we need to increase the dose in order to get some benefit, and the third group only experience side effects. So these, we know that there is individual variability in drug response and toxicity due to these genes or genetic variant. So the future of medicines, hopefully by doing a genetic test, which is a very simple vocal swab test that we do for the patient and identify patient's genes. So based on their genes and identifying those biomarkers, we can predict drug response and provide a medication that would be individualized based on their genes, and everybody would get benefit with minimum side effects. With that in mind, let us move on and discuss pharmacogenomic implementation in clinical practice. Pharmacogenomic integration into routine clinical practice has been relatively slow, despite the advancement in pharmacogenomic knowledge, genotyping technology, and strong evidence that available to support implementation of pharmacogenomic. And also, it is a benefit in optimization of therapy has been recognized by major stakeholders such as providers, physicians, and even insurances. And now, building on what we have covered, only dozens of institutions have implemented pharmacogenomic in clinical practices, and mostly they are large academic centers and universities, such as University of Colorado in Denver, where I graduated, Kaiser Permanente, University of California, San Francisco, MD St. Luke, which is a large institution that provide pharmacogenomic services, and also it is a lab that backed up by Mayo Clinic, where I got my my genetic testing done. University of Minnesota, University of Illinois at Chicago, Pittsburgh, etc. Now let us examine this pharmacogenomic implementation study that was conducted by Zakinova and colleague, which was a 12-question survey conducted at the University of California, San Francisco, and they targeted 42 medications that were commonly prescribed at their institution. And what they found was about 1/3 of providers, physicians, and pharmacists were using pharmacogenomic. And also they found that 2/3 of those providers who were not using pharmacogenomic, they expressed interest in implementing pharmacogenomic and also learning about more about pharmacogenomics. And also this study identified some barriers for implementing pharmacogenomic this clinical practice. The major one was lack of clear protocols and clinical guidelines, and also lack of education and clinical tools, among others. So that brings us to our topic, which is the impact of pharmacogenomic on medications, and this can be different depending whether the medication is a prodrug such as codeine or an active parent drug which such as citalopram. So prodrug means the medication is not active and it has to be taken by the patient and break down by patient's enzyme to the active form, in this case codeine to morphine. And if the patient is having a genetic variant that increase their ability to metabolize drug at a faster rate, then when we give them a prodrug such as codeine, they will break down much of the prodrug, inactive drug, to the active form, which is in this case morphine, and they will have a higher concentration in their body, and therefore there may be more effectiveness, but also at the same time more side effects, including respiratory depression and other side effects associated with a high concentration of morphine. On the other hand, when we give the patient an active drug such as citalopram, and the patient will break down more of the active drug to the inactive form, and therefore the patient will not get much benefit out of this medication, and their depression symptoms will not be controlled. Because the patient will break down a lot of the active to inactive, and they will have less concentration of the active medication in their body. On the flip side, when we have a patient who has a genetic variant that reduce their ability to metabolize a drug, or they have less active enzyme, when we give them a prodrug such as codeine again, which is inactive, they will convert less of codeine to active drug. So they will have less concentration of the active drug, in this case morphine, in their body, and less effectiveness, and their pain will not be controlled as it should be when you compare with a normal patient. On the other hand, when we give an active drug such as citalopram again to this patient who has reduced ability to break down medications, therefore the patient will have less ability to break down the active medication to inactive drug, and therefore they will have a high concentration of the active drug in their system, and it might be more effective, but also at the same time it can produce a lot of side effects, and it can be really discouraging for those patients, since depression can take up to 4 weeks to see the benefit, and also if they experience side effects, then that would be discouraging for the patient. So now let us examine some of the genes that impact on how our body handle medications. So the first and foremost is CYP2D6, which metabolizes up to 25% of medication available in the market today. And here we have the enzyme or the gene CYP2D6, and here we have the alleles and normal function alleles, star 1, star 2. Each one has an activity score of 1. Decreased function allele, star 9, star 17, star 41. Each one has a score activity of 0.5. and star 10 has a score activity score of 0.25. And then we have non-function alleles, star 3, star 4, star 5, and star 6. They all have activity score of 0. And then we have the phenotype, ultra rapid metabolizer, normal metabolizer, intermediate metabolizer, and poor metabolizer. And then we have the diplotype or genotype. So if we have a star 1, and N stand for numerous or multiple copy of these genotypes, star 1, then the patient is considered ultra rapid metabolizer and has activity score of more than 2.25 for the activity score for their enzyme. And in this case, if a patient is taking a prodrug, then they will experience side effects. But in case of active drug, the poor drug response is expected. This is a normal metabolizer, so normal response expected. For intermediate and poor metabolizer, in terms of a prodrug, they will have less effectiveness, and alternative drug is recommended for these patients. And if the patient is taking an active drug such as citalopram or sertraline, and those they are expected to have more side effects. And here we have the diplotype star 1, star 10. Here we have star 4, star 10, and then star 4, star 4. Both are inactive or a non-functional allele, and therefore the patient is poor metabolizer. And now let us explore CYP2C9, which is also a major enzyme that metabolize a lot of medications, and we have the normal function allele here, star 1, and we have non-function alleles, star 2, star 3. Star 2 has more activity when you compare with star 3, and just of note. We have normal metabolizer, in this case for CYP2C9 we don't have ultra rapid or rapid metabolizer, we only have normal, intermediate, and poor metabolizers. And depending on the phenotype, star 1 normal, and star 1 star 2 for example are intermediate, star 3 star 2 poor metabolizer, and more side effect expected. And let us shift our focus to discuss CYP2C19. This also a very important enzyme especially for clopidogrel, for psych meds, and a lot of other medication that metabolized by this enzyme. We have the allele. We have the star normal function allele, star 1, increased function allele, which is star 17, and then non-functional allele, star 2, star 3. We have the phenotypes, ultra rapid, normal, intermediate, and poor metabolizers, depending on which phenotype we have or diplotype. And for star 17, both are increased function allele. Then we have ultra rapid metabolizer, poor drug response expected when we give a patient an active drug. But for a prodrug, medication that is not active, that need to be metabolized by the patient's enzyme to active form, then they will experience more side effects. And in contrast, when we have an intermediate and poor metabolizer, they are expected to have more side effects with these genotypes. And now we discuss this in genes, and now let us move and talk about some medication that impacted by those genes. And this based on CP guidelines, and here we have the drugs, here we have genes. So the first one is CYP2C19, which is a major gene or enzyme for SSRI, selective serotonin reuptake inhibitor, which is a class of medication that used for anxiety, depression, and things like that, such as sertraline and citalopram. We will discuss that on later slides. And PPIs, those are medications that can be used for ulcer, acid reflux, things like that, such as omeprazole. For those, if a patient is ultra rapid metabolizer for CYP2C19, then we need to increase the dose by up to 100% for those patients who have H. pylori. And of note, when a patient is intermediate or a poor metabolizer, they will have, based on studies, shows that they have a higher success rate of H. pylori eradication when they are intermediate or poor metabolizer. We will talk about clopidogrel on a future slide. Voriconazole. So CP guideline recommend that we only use voriconazole if the patient is normal metabolizer. For ultra rapid, intermediate, or poor metabolizer, recommended to use an alternative, because with poor metabolizer they will have more side effects. In ultra rapid metabolizer, they will not get much benefit of this medication because their body will break down the medication at a faster rate. On the CYP2C9, which is an enzyme that break down phenytoin, warfarin, NSAIDs, celecoxib. So with phenytoin, if a patient, and of note, we already mentioned, we don't have a rapid or ultra rapid metabolizer for CYP2C9. We only have normal, intermediate, or poor metabolizer. So for phenytoin, if a patient is intermediate or poor metabolizer, we need to reduce the dose by up to 50%. For warfarin is very complex. We have a very nice tool online, warfarindosing.org, that you can plug in patient information, including their age, other co-administered medications that might interact with warfarin, and also their enzyme. And it's very complex because it impacted by diet, drugs, patient concomitant diseases such as liver diseases, and also genetic factors. So unless there are 3 or 4 genes that impact on warfarin, VCORC1, CYP2C9. So if the patient is poor or intermediate metabolizer, then we need to reduce the dose for warfarin drastically to avoid bleeding. And also with warfarin, there is another gene called CYP4F2. If the patient is intermediate or poor metabolizer, then we need to increase the dose for warfarin. And for NSAIDs and celecoxib, if a patient is a poor or intermediate metabolizer, depending on which medication you're using and depending on their half-life, we need to either avoid the medication and use an alternative, or reduce the dose by up to 50%, 25 up to 50%, depending on whether the patient is intermediate or poor metabolizer. For CYP2D6, we have another group of medications that are impacted by that. Tricyclic antidepressants such as amitriptyline, tamoxifen, opioids, ondansetron, SSRI, a group of SSRI such as fluoxetine, fluvoxamine, and paroxetine, also tamoxifen, aripiprazole, metoclopramide. So we will discuss some of SSRI, and also I will briefly discuss tricyclic antidepressant on future slide. But for a tamoxifen, we need to reduce the dose when the patient is intermediate or poor metabolizer for this enzyme. For opioid, as a general rule, most of opioids convert to more potent drugs. So codeine is a prodrug. It converts to morphine, and tramadol is converted to another metabolite that is 100 times more potent than tramadol. Oxycodone to oxymorphone, hydrocodone to hydromorphone, and all are more active or more potent. So when a patient is ultra rapid metabolizer, then more side effect, higher concentration of the medication, first of all, in the body, in the patient's system, and also corresponding effectiveness, higher effectiveness, and also at the same time more side effects associated with this. However, if the patient is intermediate or poor metabolizer, then when we give a patient opioids, then they might not get much benefit out of these medications, and they will not have a good analgesic effect or pain control. Same thing with ondansetron is an active drug. So if a patient is poor metabolizer, then we need to reduce the dose. If it's ultra rapid metabolizer, patient would not get much benefit, and we need to use an alternative. Tamoxifen is a drug that is used for breast cancer, and it is converted to indoxafen, which is 100 times more potent than tamoxifen. So when a patient is a poor or intermediate metabolizer, there is a high chance that the patient will not get benefit and they will have a risk of therapeutic failure. For tacrolimus, they studied tacrolimus in poor metabolizers. If a patient is a normal or intermediate metabolizer for this enzyme, and then we need to increase the dose by 1.5 to 2% of the standard dose. For this group of medication, they impacted by HLA, human leukocyte antigen type B. For abacavir, we will discuss that, but it's star 5701. For allopurinol, it's star 5801. And if a patient is positive for this gene, then they will have a high risk of skin reactions. For phenytoin, carbazepine, oxcarbazepine, they impacted by this gene, star 1502. If the patient is positive for these genes, then we need to avoid using these medications. Otherwise, they can cause severe skin allergic reaction, including Stevens-Johnson syndrome. And for azathioprine, 6-mercaptopurine, or thiogonine, those are impacted by TPMT, thiopurine methyltransferase, which is an important enzyme that breaks down these medications. So if the patient is a poor or intermediate metabolizer for this enzyme, then we need to reduce the dose drastically up to 80% for intermediate to avoid severe toxicity. Otherwise, if the patient is poor metabolizer, it's recommended to avoid unless you are using for cancer and there are no other alternatives. Then we need to use about tenth of the dose, reduce the dose by 10-fold, and use maybe 3 times a week instead of daily. So now let us take a look at some example. So the first is abacavir, which is used for HIV, and FDA and CP guidelines require that we do a genetic test for the patient before we initiate this medication. Otherwise, the patient will have a high risk of hypersensitivity allergic reactions. And if the patient is positive for this gene, then they have high risk of abacavir hypersensitivity reaction. And based on CP guidelines, it's not recommended to use. FDA package insert shows that it is contraindicated. For Department of Health and Human Services guidelines, should be not prescribed for the patient, and it should be recorded as an allergy for the patient on their profile. And there is a study, it's called PREDICT study, which is a randomized double-blind clinical trial that included 2,000 patients, 1,000 patients in each arm. And one is a control group, the other one is screen group, where they had the patient were screened for this gene, human leukocyte antigen type B star 5701. And they were excluded from the study if they were positive. Otherwise, if they were negative for this gene, then they were included in the screen arm. And the study shows that there was a significant reduction in hypersensitivity allergic reaction in the screen arm, which was 0 versus 2.7% in controlled arm. And before we move on, let us briefly discuss some medication that affect patients in cardiology. So the one that we will focus on is clopidogrel, which is a prodrug and need to be converted to active drug in the body in order to work as antiplatelet, as a blood thinner for those patients for a variety of conditions, but one that we are going to focus on is acute coronary syndrome, percutaneous coronary intervention. So those patients will go in to cath lab, and the cardiologist will put a stent. And before doing that, and also after the stent placement, the patient will be on clopidogrel. And based on CP guidelines, if a patient is intermediate, which is up to 45%, or poor metabolizer, about 15% of those people, we need to use an alternative, such as prasugrel or ticagrelor, because these patients will not benefit from clopidogrel, as they have a reduced activity for their enzyme activity, and they will not break down the medication to the active drug, and therefore they will be at risk of major adverse cardiac events and also stent thrombosis, and they might have heart attack or a stroke. Okay, and now this slide shows a screenshot from EPIC, the health system at the University of Colorado, electronic system, where the physician was trying to prescribe clopidogrel for this patient, and the patient already has pharmacogenomic testing done, and it shows that the patient is CYP2C19 intermediate metabolizer star 2 star 17, and when the physician was trying to prescribe this medication, he got alerted. This alert shows that the patient is this medication is not appropriate for the patient, and also provided the pharmacist on duty phone number for pharmacogenomic consult, and also provided the physician with some alternative, Brilinta or Effiant, prasugrel. Those two medications are not impacted by this gene and would be appropriate for these patients unless they are contraindicated. And now, to further illustrate this point, let us take a look at some of the psych meds on this slide. This shows a recommendation from CP guidelines for CYP2D6 and SSRIs, which are selective serotonin reuptake inhibitors that used for depression and anxiety and other conditions. So one that we have on this slide is paroxetine, but this applied to fluvoxamine, also fluoxetine, and some other tricyclic antidepressant. So if a patient is ultra rapid metabolizer for CYP2D6, then they will have increased enzyme activity, and they will metabolize the active drug to inactive drug, and there will be a risk of therapeutic failure. And therefore, CP guidelines strongly recommend that we use an alternative that is not impacted by CYP2D6. If a patient is a normal metabolizer, then we use the medication and just monitor the patient. If the patient is intermediate or a poor metabolizer, then we can still use the medication at standard dose for intermediate. But for poor metabolizer, we need to reduce the dose by up to 50% for selective serotonin reuptake inhibitors such as paroxetine, because the patient would be an increased risk of side effects because of they have a reduced activity of their enzyme activity, and they will not break down the medication to inactive drug, and therefore they will be at risk of toxicity and side effects. And let us shift our focus to CYP2C19 and SSRIs. And in this case, citalopram, escitalopram, and sertraline are all metabolized by CYP2C19, along with some of tricyclic antidepressant. So when a patient is ultra rapid metabolizer for CYP2C19, then they have increased enzyme activity. They will break down the active drug to inactive drug at a faster rate, and therefore it's considered in this patient alternative should be considered, that a medication that is not impacted by CYP2C19. And if a patient is normal metabolizer, then we can use the medication at a standard dose. Also, if intermediate metabolizer, they will have reduced enzyme activity and they might experience some side effects, but we still can use standard dose and monitor the patient. But if the patient is a poor metabolizer, then it's recommended to reduce the dose by 50% or use an alternative. Okay, and I would like just to briefly explain our report. So this is for our pharmacogenomic report, which of course has more than 30 pages, but this is just one section of the report which show genes and phenotype. So these are the genes CYP2D6, and this is the genotype *2, *5, and this is a diagram that show the impact of these genes, which is intermediate metabolizer in this case, and an explanation or what would happen when a patient has this gene when they take a medication that impacted by this gene. And also other genes, CYP2C9, CYP2C19, and also on this report will show factor 2, factor 5, whether the patient is at higher risk of blood clotting or thrombosis, and also MTHFR, which is the enzyme that break down folic acid to active folate form. And let us move to the next slide, and on this slide it will show more genes and phenotype, and also some of the medication. So this is the starting of the report will show medication. So here we have these in red, major gene drug interaction. So these should be avoided in the patient, or we should use alternative, or if we have to use this medication, you have to use a lower dose, a lot lower than normal. So capecitabine and also fluorouracil or 5-FU, those are impacted by PDYD, and in this case the patient is poor metabolizer, and we need to avoid this or use a lower dose. And then here we have mercaptopurine, also metabolized by TPMT, thiopurine methyltransferase. And in this case, since the patient is a poor metabolizer for this enzyme, and of course these are two different patients. This is a report for a patient that I just got a screenshot for that portion, and this is another patient. So two different patients, but I just want to show you when the patient has a major gene drug interaction. Over here we have moderate gene drug interaction. We don't have any medication for this patient, but we have these medication in green. They are safe to be used for this patient based on their genes. And then those have a limited studies or information. And then this another section of that report, which covers some of the psych meds. So all these medication have major drug gene interaction and should not be used for this patient. Those are some of the safe medication. So if a patient need medication for depression, citalopram would not be appropriate. We can use bupropion or Wellbutrin. And this is a patient who was admitted to the hospital, and he was 60 years old, white male, admitted to hospital for PCI, and they started him on clopidogrel. And the patient was intermediate metabolizer for CYP2C19, star 1, star 3, and when we did the genetic test for the patient, and this is his report that shows that patient was intermediate metabolizer for that enzyme, and then we recommended to the physician that we use prasugrel 10 milligram daily instead of clopidogrel. Otherwise, the patient would be at risk of stent thrombosis and also major adverse cardiac events such as heart attack or stroke. Okay, and now let us shift gears and talk about some of the oncology medications or cancer medications. On this slide shows some of the targeted agents, and of course there are hundreds of other targeted agents that are approved by FDA that come with FDA approved test for pharmacogenomics. And from their names, targeted agents, they target certain molecule in the body. If the body doesn't have those molecules, those medication they are not helpful, and it's just wasting time, money, and putting the patient at high risk. So the first one is trastuzumab or Herceptin, which is a first-line agent for HER2-positive breast cancer, which inhibit HER2 signaling pathway activity in tumor cells, and it is life-saving for those patients who are HER2 positive, but it is not beneficial for those who have who are HER2 negative. So we can only use this when the patient is HER2 positive. And the other agent is pembrolizumab, Keytruda, which is a first-line agent for non-small cell lung cancer with high PD-L1 expression. And this stands for programmed that ligand 1, and if the patient is negative or doesn't have much, at least 50% of these ligand, then using this pembrolizumab is not helpful, and it should not be used. And also the patient should have no EGFR or ALK in order to qualify for using pembrolizumab. And now let us discuss some of the chemotherapy that is used for cancer. And mainly on this slide, we are going to discuss fluoropyrimidines, 5-FU or fluorouracil, and capecitabine. 5-fluorouracil is a IV medication, and this one is oral medication using tablets. And this one is converting to the 5-fluorouracil in the body. And if the patient and this both drug metabolized by DPYD, the hydropyridine dehydrogenase enzyme, and if the patient is intermediate or poor metabolizer for this enzyme, the patient will not break down much of the active drug to the inactive form, and therefore the patient will be at high risk of severe toxicity, including fatal drug toxicity such as neutropenia or very low count of a white VC, and put the patient at risk of severe infections. And if the patient is a poor metabolizer, it's recommended to avoid. If there are no other choices, then we need to use less than 25% of the normal starting dose. And for those who are intermediate, we use 25 to 50% of the normal dose. And now, as we conclude our presentation, I would like to leave you with some resources and some food for thoughts. So that way you can educate yourself more and learn more if you are interested in pharmacogenomics. And the first one is CP guideline, which is a major clinical guidelines that help us with the pharmacogenomic interpretations and also drug-gene interactions. Also, I have my website here, www.rashorx.com. I have a lot of resources on my website that you can use and help, and also it shows our contact information if you are interested in doing a pharmacogenomic test for yourself as a patient, or if you have patients as a provider, if you are interested, we can help set up that for you at your clinical practice. And we have PharmGKB, another good or great resource similar to CP guidelines, DPWG or Dutch guidelines, which is a European guideline, Ignite Spark, Emerge Clinical Decision Support knowledge base. And we have here warfarinedosing.org, which is a great resource. As I previously explained, that you can put the patient, plug in patient information, including their age, concomitant diseases, and other medications that the patient are using, along with their genetic results, and it will show you the starting dose or loading dose, and also maintenance dose for warfarin, and CleanVar, and also some educational resources for patients. Okay, so that brings us to our the end of our presentation, and in summary, I hope this was very beneficial for you, and I hope that you see that pharmacogenomic is a very important tool that we can add to our toolbox in order to optimize therapy and help us in drug selection and dosing to optimize drug therapy, maximum effect and minimum side effects by identifying those biomarkers that the patient have. So that would be our goal in the future, and that would be the future of our practice. And this is where we are now, and this is what we are hoping to get into the future. And here are my references. And with that, we got to the end of our discussion for today. Thank you so much for your time and your attention. Have a nice day. Okay, on this slide, I would like to talk about some of the services that we provide at Rasho RX. One of them is pharmacogenomic testing and consultation that can help you find the right medication based on your gene and DNA for a variety of conditions such as depression and anxiety, heart diseases, and cancer, and also pain management and other conditions. And the genetic test is a very comprehensive test. It covers hundreds of medications, as I mentioned, many conditions and genes that can have impact on the medication and the way our body handle medications. And though these genetic report is covered by most of insurances here in the United States, such as Medicare, Medicaid, and TRICARE cover these genetic tests, as well as some of other commercial insurance. For overseas and over here in the United States, for cash payment, you just reach out to us or our contact information here, and we'll be happy to reach out to you and help you with this genetic test as much as we can. This is our phone number. We are also available on WhatsApp. And here is our website, rashorx.com. And we have a lot of information on our website that you can check. And also we are available on social media such as Facebook, Instagram, LinkedIn, and also Twitter. Same Rasho RX. And also we have our email address. If you have any question and interested in doing pharmacogenomic for yourself or for a family member, or if you are a provider and looking to get these genetic tests done as a part of your clinical practice to improve patient health, we will be happy to help you with that. And this is our genetic test, right mid. And let me go ahead and open it and see what is inside. So first, when you open it, it shows some of the instruction on here. And inside we have the our testing tube, and we have a package that it's a biospecimen package that we put the testing tube inside after we are done. And we have some instruction how to take the test, and we have a label, prepaid label, and also a FedEx package. After you are done, you send to our facility so we can do the test. So let me go ahead briefly to tell you how to take the test. So this is the testing tube, and we have a red arrow here. It says open, so you just peel this, open it, and then take the testing tube. Make sure that it doesn't touch the sponge tip, doesn't touch anything. And the way you take this test is through your mouth. So you put the sponge as much as you can inside your mouth, between the gum and cheek on both sides, and then do it in a back and forth motion like this for 10 times. Same thing on the other side. Then hold it vertically like this, and open this blue cap, invert the sponge tip, so that way it's inside the testing tube and it's touching this preservative fluid. And then close it tightly, shake it vigorously for 10 times, and then it is ready. The most important thing, that you don't eat, drink, chew gum, or smoke. So nothing 30 minutes prior to taking the test. No eating, drinking, chewing gum, or smoking for 30 minutes. After that, after you do the test, that's fine. But before the test, for 30 minutes, nothing. And then you take the test. Make sure that you look at this, that is not expired. We will never send one that expired, but just double check that. Put your name, full name, first and last name, and your birthday with a Sharpie on this testing tube before you seal it. Put it in the bag and seal it. And activate the test. If you are doing it yourself, make sure, I will send you a link. Make sure you put this barcode in there, and also the day that you collected the sample. And then it's ready. You put in this biospecimen bag, and you remove or peel this blue tape, and there is some glue here. Seal the bag, and then this bag will go inside this package. Put the package inside the FedEx package and label it and send it to our facility, our lab, so that we can go ahead and take a look at that and get your result back to you. And if you are sending from Iraq, this prepaid package doesn't work, so you have to put everything in this package and take it to a FedEx facility, and from there send it to our facility. And with that, that's it for the testing and how to take tests. If you have any questions, let us know.